My presentation is on OCD environmental and cultural factors. For media, it's often portrayed in movies and TV shows as OCD people are intelligent and high functioning. It's also seen as a form of comedic relief. It's usually not shown as a real illness, more shown as a quirky habit. It doesn't show that there are different levels of symptoms and the ability to function per person, and it rarely shows them getting treatment. The media limits the types of symptoms shown, thereby stereotyping the disorder and potentially fostering public misunderstanding and stigma. Over half of the programs suggested that forming valuable social relationships can help people with mental disorders improve or overcome their problems. For family support, there's internalizing and externalizing behaviors. 62% of parents endorsed often or always when externalizing factor. There's a greater emphasis needed for parent behavioral training and motivational enhancement. There is a program called Family Inclusive Treatment, also known as FIT, which is associated with greater improvements in patient functioning. The specific attention is to modifying maladaptive patterns of interaction and developing more effective family coping with symptoms, which may have a greater impact than the sheer number of hours families spend in treatment. Children with OCD are often worse at social functioning and fear negative evaluation. They have increased peer victimization and tend to have fewer friends. Parents are encouraged to facilitate social interactions for their children. There is shown to have a genetic factor. Studies have shown that people with first-degree relatives, such as a parent, sibling, or child who have OCD, are at a higher risk for developing OCD themselves. The risk is higher if the first-degree relative developed OCD as a child or a teen. An association between childhood trauma and obsessive-compulsive symptoms have been reported in some studies. More research is needed to understand this relationship better. In some cases, children may develop OCD or OCD symptoms following streptococcal infection. This is called pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, also known as PANDAS. For the legal and political system, there's the American with Disabilities Act. OCD can be covered as a long-term or permanent mental limitation as long as they can do the main part of the job with or without help. Employers apply when it comes to private employers and religious entities with at least 15 employees, state and local governments, employment agencies, and labor unions. Reasonable accommodation means to change some part of work so that a person with a disability can do the job. The change can include providing a quiet place to work, giving assignments and instructions in writing instead of orally, or modifying work schedules, and so on. People with the Disabilities Act are protected against discrimination. They are not forced to tell anyone, but if the illness, such as OCD, can negatively impact the work and it can be showing themselves as slow, incompetent, or lazy, and leads to poor performance reviews, counseling, discipline, or other problems at work, it should be time where they consider disclosing the disability so they can ask for reasonable accommodation. There's also the Protecting Students and Children with OCD Act of 1973. Potential barriers. People with OCD are socially isolated or rejected due to obsessions related to contamination, harming, or sexual obsessions. And they'd be less likely to reveal sexual obsessions to others if they're experiencing them than the other types of obsessions stated previously. They also may fear criminalization. There can be a stigma against mental illness. There are internal and cognitive factors, and there are also those who don't know what their problem is or that they have a problem. And then there can be factors relating to their treatment. For the international scope, East Asians have a more negative view on mental illness overall and are more likely to blame the individual. They consider OCD to be part of an individual's personality, not an illness, and they recommend alternative therapies rather than psychosocial or medication help. Western countries have more favorable view on illnesses and encourage psychosocial interventions. There can be barriers to treatment based on socioeconomic status, which can include the cost of treatment, poor knowledge of how the healthcare system works, the geographic availability or unavailability of resources, and their lack of understanding of mental illnesses. For race and ethnicity, ethnic minorities are often underrepresented in clinical settings, and they have different views and health beliefs. There's often a stigma or discrimination from within their own communities, which can cause shame and denial. There's also can be a general lack of trust in the healthcare system by their cultural group, and different beliefs about mental health issues that can cause them to feel discriminated from within the system. For religion, those who identify as Catholic have had the highest level of scrupulosity as opposed to those who identify as Protestant, Jewish, or having no religion. The magnitude of these relationships differed by religious affiliation. Scrupulosity was associated with OCD symptom severity globally and across symptom dimensions. Scrupulosity, but not OCD symptoms in general, differ across religious affiliations. Scrupulosity is the religious form of OCD. It is essentially an excessive or debilitating concern with morality. There were mixed findings for gender results. OCD showed to be more present in males during childhood, while females more present in adolescence. Females tended to report higher depression and anxiety levels, but there's no reported differences in treatment outcomes by gender. For geographical location, there is video teleconferencing, also known as VTC, which extends reach of real-time expert services regardless of their geographic proximity to quality care. There's also remote treatment for OCD, which decrease in symptoms in a large magnitude, but no significant difference from face-to-face treatment. Bias. There can be both implicit and explicit biases. The implicit would be negative response or attitude towards the idea or diagnosis of a mental illness, and there could be social distancing related to bad experiences previously or lack of knowledge from mental illnesses from others. The explicit can be both social and internalized. Social would be attitudes of the public in relation to mental illness, while internalized is the stigma felt by each person in relation to mental illness. For social, there can be the psychiatric label, which is known as a negative stereotype, social, economic, and political power inequality for those with mental illness. And for internalization, there's the fear or pity response, which can create rejecting behaviors such as avoidance, corrosion, or segregation. For international scope, there's not one region in particular that would not be affected by OCD and its complications. There are no specific regions that have purely rich Caucasian male or females who are not affected by OCD thoughts related to religion. Ultimately, the Western countries would be less affected, as it has been noticed in previous slides that receiving psychiatric help is less taboo in comparison to Eastern countries. It's also shown that the higher working class, the more that they can pay for the treatments, education for understanding and being willing to seek help, and then of course access to treatment centers. And these are my references. Thank you.